The pathogenesis of these other autoimmune polyendocrinopathies is not understood. Infections, particularly tuberculosis and those produced by fungi, may also cause primary chronic adrenocortical insufficiency. Tuberculous adrenalitis, which once accounted for as much as 90% of cases of Addison disease, has become less common with the development of antimycobacterial drugs. With the resurgence of tuberculosis in most urban centers and the persistence of the disease in lower-income countries, however, this cause of adrenal insufficiency must be kept in mind. When present, tuberculous adrenalitis is usually associated with active infection in other sites, particularly in the lungs and genitourinary tract. Among fungi, disseminated infections caused by Histoplasma capsulatum and Coccidioides immitis may result in chronic adrenocortical insufficiency. AIDS patients are at risk for developing adrenal insufficiency from several infectious and non-infectious complications. Metastatic neoplasms involving the adrenals are another cause of adrenal insufficiency. The adrenals are a fairly common site for metastases in patients with disseminated carcinomas. Although adrenal function is preserved in most such patients, the metastatic tumors occasionally destroy enough adrenal cortex to produce a degree of adrenal insufficiency. Carcinomas of the lung and breast are the source of a majority of metastases, although many other neoplasms, including gastrointestinal carcinomas, malignant melanoma, and hematopoietic neoplasms, may also metastasize to the adrenals. Genetic causes of adrenal insufficiency include congenital adrenal hypoplasia and adrenoleukodystrophy. Adrenoleukodystrophy is caused by mutations of the ATP binding cassette, subfamily D, member 1 gene and is further described in Chapter 28. Congenital adrenal hypoplasia is a rare X-linked disease caused by mutations in the NNROB1 gene that encodes DDX1, a transcription factor implicated in adrenal development. Morphology. The anatomic changes in the adrenal glands depend on the underlying disease. Primary autoimmune adrenalitis is characterized by irregularly shrunken glands, which may be difficult to identify within the suprarenal adipose tissue. Histologically, the cortex contains only scattered residual cortical cells in a collapsed network of connective tissue. A variable lymphoid infiltrate is present in the cortex and may extend into the adjacent medulla, although the medulla is otherwise preserved. In cases of tuberculous and fungal disease, the adrenal architecture is effaced by a granulomatous inflammatory reaction identical to that encountered in other sites of infection. When hypoadrenalism is caused by metastatic carcinoma, the adrenals are enlarged and the normal architecture is obscured by the infiltrating neoplasm. Clinical features. Addison disease begins insidiously and does not come to attention until the levels of circulating glucocorticoids and mineralocorticoids are significantly decreased. The initial manifestations include progressive weakness and easy fatigability, which may be dismissed as nonspecific complaints. Gastrointestinal disturbances are common and include anorexia, nausea, vomiting, weight loss, and diarrhea. In individuals with primary adrenal disease, figure 24.49 autoimmune adrenalitis. In addition to loss of all but a subcapsular rim of cortical cells, there is an extensive mononuclear cell infiltrate. Hyperpigmentation of the skin, particularly of sun-exposed areas and at pressure points, such as the neck, elbows, knees, and knuckles, is quite characteristic. This is caused by elevated levels of pro-opiomelanocortin, which is derived from the anterior pituitary and is a precursor of both ACH and melanocite-stimulating hormone. By contrast, hyperpigmentation is not seen in persons with adrenocortical insufficiency caused by primary pituitary or hypothalamic disease. Decreased mineralocorticoid activity in persons with primary adrenal insufficiency results in potassium retention and sodium loss, with consequent hyperkalemia, hyponatremia, volume depletion, and hypotension. Hypoglycemia may occasionally occur as a result of glucocorticoid deficiency and impaired gluconeogenesis. Stresses such as infections, trauma, or surgical procedures in such patients can precipitate an acute adrenal crisis, manifested by intractable vomiting, abdominal pain, hypotension, coma, and vascular collapse. Death occurs rapidly unless corticosteroid therapy begins immediately. Key concepts: adrenocortical insufficiency. Primary adrenocortical insufficiency can be acute or chronic. Chronic adrenal insufficiency in the developed world most often is secondary to autoimmune adrenalitis, which occurs most commonly in the context of one of two autoimmune polyendocrine syndromes, APS-1 or APS-2. I is characterized by an autoimmune attack against multiple endocrine organs and autoantibodies against IL-17 and IL-22. tuberculosis and infections due to opportunistic pathogens associated with the human immunodeficiency virus and tumors metastatic to the adrenals are the other important causes of chronic hypoadrenalism. Patients typically present with fatigue, weakness, and gastrointestinal disturbances. Primary adrenocortical insufficiency also is characterized by high ACH levels with associated skin pigmentation. Secondary adrenocortical insufficiency. Any disorder of the hypothalamus and pituitary, such as metastatic cancer, infection, infarction, or irradiation, that reduces the output of ACH leads to a syndrome of hypoadrenalism that has many similarities to Addison disease. Analogously, prolonged administration of exogenous glucocorticoids suppresses the output of ACH and adrenal function. With secondary disease, the hyperpigmentation of primary Addison disease is lacking because levels of melanocyte-stimulating hormone are not elevated. The manifestations also differ in that secondary hypoadrenalism is characterized by deficient cortisol and androgen output but normal or near normal aldosterone synthesis. Thus, in adrenal insufficiency secondary to pituitary malfunction, marked hyponatremia and hyperkalemia are not seen. ACH deficiency can occur alone, but in some instances it is only one component of panhypopituitarism, associated with multiple trophic hormone deficiencies. Secondary disease can be differentiated from Addison disease by demonstration of low levels of plasma ACTH in the former. In patients with primary disease, the destruction of the adrenal cortex reduces the response to exogenously administered ACH, whereas in those with secondary hypofunction, there is a prompt rise in plasma cortisol levels. Morphology. In cases of hypoadrenalism secondary to hypothalamic or pituitary disease, depending on the severity of ACH deficiency, the adrenals may be moderately to markedly decreased in size. The small, flattened glands usually retain their yellow color as a result of a small amount of residual lipid. The cortex may be reduced to a thin ribbon composed largely of zona glomerulosa. The medulla is not affected. Adrenocortical neoplasms. It should be evident from the preceding sections that functional adrenal neoplasms may be responsible for any of the various forms of hyperadrenalism. Adenomas and carcinomas are about equally common in adults. In children, carcinomas predominate. While most cortical neoplasms are sporadic, two familial cancer syndromes are associated with a predisposition for developing adrenocortical carcinomas: Lee-Fraumeni syndrome, caused by germline TP53 mutations, and Beckwith-Wiedemann syndrome, a disorder of epigenetic imprinting involving the gene for insulin-like growth factor 2. Interestingly, somatic TP mutations and overexpression of IGF also occur in sporadic adrenocortical carcinomas, reiterating an oft-observed phenomenon of shared molecular mechanisms in familial and sporadic neoplasms. Functional adenomas are most commonly associated with hyperaldosteronism and Cushing syndrome, whereas a virilizing neoplasm is more likely to be a carcinoma. However, not all adrenocortical neoplasms elaborate steroid hormones. Determination of functionality is based on clinical evaluation and measurement of hormones or hormone metabolites in the blood. Morphology. Most adrenocortical adenomas are clinically silent and are usually incidental findings at autopsy or during abdominal imaging for an unrelated cause. The typical cortical adenoma is a well-circumscribed nodular lesion up to 2.5 centimeters in diameter that expands the adrenal. In contrast to a functional adenoma, which is associated with atrophy of the adjacent cortex, the cortex adjacent to a non-functional adenoma is normal. On cut surface, adenomas are usually yellow to yellow-brown because of the presence of lipid. Microscopically, adenomas are composed of cells similar to those populating the normal adrenal cortex. The nuclei tend to be small, although some degree of pleomorphism may be encountered, even in benign lesions. The cytoplasm of the neoplastic cells ranges from eosinophilic to vacuolated, depending on their lipid content. Mitotic activity is generally inconspicuous, with a Ki-67 labeling index less than 5%. Figure 24.50 adrenal cortical adenoma. The adenoma is distinguished from nodular hyperplasia by its solitary circumscribed nature. The functional status of an adrenal cortical adenoma cannot be predicted from its gross or microscopic appearance. Figure 24.51 histologic features of an adrenal cortical adenoma. The neoplastic cells are vacuolated because of the presence of intracytoplasmic lipid. There is mild nuclear pleomorphism. Mitotic activity and necrosis are not seen. Adrenocortical lesions, both adenomas and carcinomas, express steroidogenic factor 1 and inhibin alpha. Adrenocortical carcinomas are rare neoplasms that have a bimodal distribution in the first and fifth decades of life. They are more likely to be functional than adenomas and are often associated with virilism or other clinical manifestations of hyperadrenalism. In most cases, adrenocortical carcinomas are large, invasive lesions, many exceeding 20 centimeters in diameter, which efface the native adrenal gland. The less common, smaller, and better circumscribed lesions may be difficult to distinguish from an adenoma. On cut surface, adrenocortical carcinomas are typically variegated, poorly demarcated lesions containing areas of necrosis, hemorrhage, and cystic change. Adrenal cancers have Figure 24.52 adrenal carcinoma. The hemorrhagic and necrotic tumor dwarfs the kidney and compresses the upper pole. Figure 24.53 adrenal carcinoma revealing marked anaplasia, contrasted with normal adrenal cortical cells. A strong tendency to invade the adrenal vein, vena cava, and lymphatics. Metastases to regional and periaortic nodes are common, as is distant hematogenous spread to the lungs and other viscera. The median patient survival is about 2 years. Microscopically, adrenocortical carcinomas may be composed of well-differentiated cells, resembling those seen in cortical adenomas, or bizarre monstrous giant cells which may be difficult to distinguish from those of an undifferentiated carcinoma metastatic to the adrenal. Between these extremes are cancers with moderate degrees of anaplasia, some composed predominantly of spindle cells. In addition to higher Ki-67 index, carcinomas also have significantly higher IGF-2 levels compared to adrenocortical adenomas. Carcinomas, particularly those of bronchogenic origin, may metastasize to the adrenals, and may be difficult to differentiate from primary cortical carcinomas. Of note, metastases to the adrenal cortex are significantly more common than primary adrenocortical carcinomas. Other adrenal lesions. Adrenal cysts are relatively uncommon, however. With the use of sophisticated abdominal imaging techniques, the frequency of detection of these lesions is increasing. Larger cysts may produce an abdominal mass and flank pain. Both cortical and medullary neoplasms may undergo necrosis and cystic degeneration, and may present as non-functional cysts. Adrenal myelolipomas are unusual benign lesions composed of mature fat and hematopoietic cells. Although most of these lesions represent incidental findings, occasional myelolipomas may reach massive proportions. Histologically, mature adipocytes are admixed with aggregates of differentiating hematopoietic cells belonging to all three lineages. Foci of myelolipomatous change may be seen in cortical tumors and in adrenals with cortical hyperplasia. The term adrenal incidentaloma is a half-facetious moniker that has crept into the medical lexicon as advancements in medical imaging have led to the incidental discovery of adrenal masses in asymptomatic individuals or in individuals in whom the presenting complaint is not directly related to the adrenal gland. The estimated population prevalence of incidentalomas discovered by imaging is approximately 4%, with an age-dependent increase in prevalence. Fortunately, the vast majority of these lesions are small, non-secreting cortical adenomas of no clinical importance. Adrenal medulla. The adrenal medulla is developmentally, functionally, and structurally distinct from the adrenal cortex. It is composed of specialized neural crest cells, termed chromaffin cells, and their supporting cells. The adrenal medulla is the major source of catecholamines in the body. Neuroendocrine cells similar to chromaffin cells are widely dispersed in an extra-adrenal system of clusters and nodules that, together with the adrenal medulla, make up the paraganglion system. These extra-adrenal paraganglia are closely associated with the autonomic nervous system and can be divided into 3 groups based on their anatomic distribution: branchiomeric, intravagal, and aorticosympathetic. The branchiomeric and intravagal paraganglia associated with the parasympathetic system are located close to the major arteries and cranial nerves of the head and neck and include the carotid bodies. The intravagal paraganglia, as the term implies, are distributed along the vagus nerve. The aorticosympathetic chain is found in association with segmental ganglia of the sympathetic system and therefore is distributed mainly alongside of the abdominal aorta. The organs of Zucker-Kandel, close to the aortic bifurcation, belong to this group. The most important diseases of the adrenal medulla are neoplasms, which include neoplasms of chromaffin cells, and neuronal neoplasms. Neuroblastomas and other neuroblastic tumors are discussed in Chapter 10. Pheochromocytoma. Pheochromocytomas are neoplasms composed of chromaffin cells, which synthesize and release catecholamines and, in some instances, peptide hormones. It is important to recognize these tumors because they are a rare cause of surgically correctable hypertension. Traditionally, the features of pheochromocytomas have been summarized by the rule of 10 seconds. 10% of pheochromocytomas are extraadrenal, occurring in sites such as the organs of Zuckerkandl and the carotid body. Pheochromocytomas that develop in extraadrenal paraganglia are designated paragangliomas and are discussed in Chapter 16. 10% of sporadic adrenal pheochromocytomas are bilateral. This figure may rise to as high as 50% in cases that are associated with familial tumor syndromes. 10% of adrenal pheochromocytomas are biologically malignant, defined by the presence of metastatic disease. Malignancy is more common in extraadrenal paragangliomas and in tumors arising in the setting of certain germline mutations. 10% of adrenal pheochromocytomas are not associated with hypertension. Of the 90% that present with hypertension, approximately 2/3 have paroxysmal episodes associated with a sudden rise in blood pressure and palpitations, which can, on occasion, be fatal. One traditional rule that has now been modified pertains to familial cases. It is now recognized that as many as of individuals with pheochromocytomas and paragangliomas harbor an oncogenic germline mutation. These mutations can involve at least a dozen genes, the most common of which are listed in Table 24.11. Patients with germline mutations are typically younger at presentation than those with sporadic tumors and more often have bilateral tumors. The affected genes fall into two broad classes: those that enhance growth factor receptor pathway signaling, and those that increase the activity and stability of two hypoxia-induced transcription factors, HIF-1 and HIF-2. You will recall that the VHL gene encodes a tumor suppressor protein that is needed for the oxygen-dependent degradation of HIF, and that is disrupted by loss-of-function mutations in patients with von Hippel-Lindau syndrome. VHL syndrome is associated with a number of tumors, including pheochromocytomas and paragangliomas. Similarly, EPase-1 encodes HIF-2-alpha, and gain-of-function mutations are found in individuals with the polycythemia paraganglioma syndrome that stabilize HIF-2-alpha by mutating amino acid residues that are required for its degradation. Other familial cases of pheochromocytoma are associated with germline mutations in genes encoding several components of the succinate dehydrogenase complex. This complex is involved in mitochondrial electron transport and oxygen sensing, and it is believed that these mutations also lead to upregulation of HIF protein, recapitulating pseudohypoxia. Recent integrated molecular analyses of pheochromocytomas and paragangliomas have shown that many of the genes implicated in a germline predisposition to these neoplasms also are involved by somatic mutations in sporadic tumors. Table: Familial syndromes associated with pheochromocytoma and extraadrenal paragangliomas. GIST: gastrointestinal stromal tumor. GN: ganglioneuroma. NF: neurofibromin. SDHB: succinate dehydrogenase complex. Subunit B: SDHC: succinate dehydrogenase complex. Subunit C: SDHD: succinate dehydrogenase complex. Subunit D: EPase: endothelial PS domain containing. Note: additional rare syndromes associated with pheochromocytoma or paragangliomas are not included in this table. Figure 24.54 Pheochromocytoma. The tumor is enclosed within an attenuated cortex and demonstrates areas of hemorrhage. The comma-shaped residual adrenal is seen below. Morphology: pheochromocytomas range from small, circumscribed lesions confined to the adrenal to large hemorrhagic masses weighing kilograms. The average weight of a pheochromocytoma is 100 grams, but weights from just over 1 gram to almost 4,000 grams have been reported. The larger tumors are well demarcated by either connective tissue or compressed cortical or medullary tissue. Richly vascularized fibrous trabeculae within the tumor produce a lobular pattern. In many tumors, remnants of the adrenal gland can be seen, stretched over the surface or attached at one pole. On section, the cut surfaces of smaller pheochromocytomas are yellow-tan. Larger lesions tend to be hemorrhagic, necrotic, and cystic, and typically efface the adrenal gland. Incubation of fresh tissue with a potassium dichromate solution turns the tumor a dark brown color due to oxidation of stored catecholamines, thus the term chromophin. The histologic pattern in pheochromocytoma is quite variable. The tumors are composed of clusters of polygonal to spindle-shaped chromophin cells or chief cells that are surrounded by supporting sustentacular cells, creating small nests or alveoli that are supplied by a rich vascular network. Uncommonly, the dominant cell type is a spindle or small cell. Various patterns can be found in any one tumor. The cytoplasm has a finely granular appearance, best demonstrated with silver stains, due to the presence of granules containing catecholamines. The nuclei are usually round to avoid, with a stippled salt and pepper chromatin that is characteristic of neuroendocrine tumors. Electron microscopy reveals variable numbers of membrane-bound, electron-dense secretory granules. Immunoreactivity for neuroendocrine markers is seen in the chief cells, while the peripheral sustentacular cells stain with antibodies against S100, a calcium-binding protein expressed by a variety of mesenchymal cell types. Figure 24.55 pheochromocytoma, demonstrating characteristic nests of cells with abundant cytoplasm. Granules containing catecholamine are not visible in this preparation. It is not uncommon to find bizarre cells, even in pheochromocytomas that are biologically benign. Figure 24.56 electron micrograph of pheochromocytoma. This tumor contains membrane-bound secretory granules in which catecholamines are stored. Determining malignancy in pheochromocytomas can be vexing. Several histologic features, such as numbers of mitoses, confluent tumor necrosis, and spindle cell morphology, have been associated with an aggressive behavior and increased risk of metastasis, but are not entirely reliable. Tumors with benign histologic features may metastasize, while bizarrely pleomorphic tumors may remain confined to the adrenal gland. In fact, cellular and nuclear pleomorphism, including the presence of giant cells, and mitotic figures are often seen in benign pheochromocytomas, while cellular monotony is paradoxically associated with aggressive behavior. Even capsular and vascular invasion may be encountered in benign lesions. Therefore, the definitive diagnosis of malignancy in pheochromocytomas is based exclusively on the presence of metastases. These may involve regional lymph nodes as well as more distant sites, including liver, lung, and bone. Clinical features. The dominant clinical manifestation of pheochromocytoma is hypertension, observed in 90% of patients. Approximately 2/3 of patients with hypertension demonstrate paroxysmal episodes, which are described as an abrupt, precipitous elevation in blood pressure associated with tachycardia, palpitations, headaches, sweating, tremor, and a sense of apprehension. These episodes may also be associated with pain in the abdomen or chest, nausea, and vomiting. Isolated paroxysmal episodes of hypertension occur in less than 1/2 of patients. More commonly, patients demonstrate chronic, sustained elevation in blood pressure punctuated by the aforementioned paroxysms. The paroxysms may be precipitated by emotional stress, exercise, changes in posture, and palpation in the region of the tumor. Urinary bladder paragangliomas occasionally precipitate a paroxysm during micturition. The elevations of blood pressure are induced by the sudden release of catecholamines that may acutely precipitate congestive heart failure, pulmonary edema, myocardial infarction, ventricular fibrillation, and cerebrovascular accident. The cardiac complications have been attributed to what has been called catecholamine cardiomyopathy, or multiple endocrine neoplasia syndromes. The MEN syndromes are a group of inherited diseases resulting in proliferative lesions of multiple endocrine organs. Like other inherited cancer disorders, endocrine tumors arising in the context of MEN syndromes have certain distinct features that contrast with their sporadic counterparts. Tumors occur at a younger age than sporadic tumors. They arise in multiple endocrine organs, either synchronously or metachronously. Even in one organ, the tumors are often multifocal. The tumors are usually preceded by an asymptomatic stage of hyperplasia involving the cell of origin. For example, individuals with MEN2 almost universally demonstrate C-cell hyperplasia in the thyroid parenchyma adjacent to medullary thyroid carcinomas. These tumors are usually more aggressive and recur in a higher proportion of cases than do similar sporadic endocrine tumors. Multiple endocrine neoplasia, type 1. MEN1, or Wermer syndrome, is a rare heritable disorder with a prevalence of about 2 per 100,000. MEN1 is characterized by abnormalities involving the parathyroid, pancreas, and pituitary gland. Thus, the mnemonic device, the 3 Ps. Parathyroid, primary hyperparathyroidism, is the most common manifestation of MEN1 and is the initial manifestation of the disorder in most patients, appearing in almost all patients by 40 to 50 years of age. Parathyroid abnormalities include both hyperplasia and adenomas. Pancreas, endocrine tumors of the pancreas are a leading cause of morbidity and mortality in persons with MEN. These tumors are usually aggressive and often present with metastatic disease. It is not uncommon to find multiple microadenomas scattered throughout the pancreas in conjunction with 1 or 2 dominant lesions. Catecholamine-induced myocardial instability and ventricular arrhythmias, non-specific myocardial changes such as focal necrosis, mononuclear infiltrates, and interstitial fibrosis, have been attributed either to ischemic damage secondary to catecholamine-induced constriction of myocardial blood vessels or to direct catecholamine toxicity. In some cases, pheochromocytomas secrete other hormones, such as ACTH and somatostatin. and may therefore be associated with clinical features related to the secretion of these or other peptide hormones. Laboratory diagnosis of pheochromocytoma is based on the demonstration of increased urinary excretion of free catecholamines and their metabolites, such as vanillylmandelic acid and metanephrines. Isolated benign tumors are treated with surgical excision after preoperative and intraoperative medication with adrenergic blocking agents to prevent a hypertensive crisis. Multifocal lesions require long-term medical treatment for hypertension. MEN1-associated pancreatic endocrine tumors are often functional. However, because pancreatic polypeptide is the most commonly secreted product, many tumors fail to produce an endocrine hypersecretion syndrome. Among those that do, Zollinger-Ellison syndrome and hypoglycemia and neurologic manifestations are most common. Pituitary. The most frequent anterior pituitary tumor encountered in MEN-1 is a prolactinoma. Some patients develop acromegaly from somatotropin-secreting tumors. It is now recognized that the spectrum of this disease extends beyond the 3 Ps. The duodenum is the most common site of gastrinomas in individuals with MEN1, and synchronous duodenal and pancreatic tumors may be present in the same individual. In addition, carcinoid tumors, thyroid and adrenocortical adenomas and lipomas are more frequent than in the general population. MEN1 syndrome is caused by germline mutations in the MEN1 tumor suppressor gene, which encodes a protein called menin. Menin is a component of several different transcription factor complexes, which may either promote or inhibit tumorigenesis. This dichotomy in menin function is best exemplified in the interactions of menin with 2 oncogenic transcription factors, JUND and KMT2A, a chromatin-modifying histone methyltransferase. When menin partners with JUND, it blocks transcriptional activation and cellular proliferation induced by JUND. In fact, loss of this tumor suppressor interaction is believed to contribute to the MEN observed in the setting of MEN-1 inactivating mutations. On the contrary, the association of wild-type menin with KMT2A leads to the formation of a tumor-promoting transcriptional complex in a subset of acute leukemias through upregulated expression of Hox genes. The dominant manifestations of MEN1 usually result from the peptide hormones that are overproduced and include such abnormalities as recurrent hypoglycemia due to insulinomas, intractable peptic ulcers in persons with Zollinger-Ellison syndrome, nephrolithiasis caused by PTH-induced hypercalcemia, or symptoms of prolactin excess from a pituitary tumor. As expected, malignant behavior by one or more of the endocrine tumors arising in these patients is often the proximate cause of death. Multiple endocrine neoplasia, type 2. MEN is subclassified into 3 distinct syndromes, MEN-A, MEN-B, and MEN. MEN-A or Sippel syndrome is characterized by pheochromocytoma, medullary carcinoma of the thyroid, and parathyroid hyperplasia. Medullary carcinomas of the thyroid occur in almost 100% of patients. They are usually multifocal and are virtually always associated with foci of C-cell hyperplasia in the adjacent thyroid. The medullary carcinomas may elaborate calcitonin and other active products and are usually clinically aggressive. Among individuals with MEN2A, 40% to 50% have pheochromocytomas, which are often bilateral and may arise in extra-adrenal sites. Parathyroid hyperplasia and evidence of hypercalcemia or renal stones occur in 10% to 20% of patients. MEN2A is clinically and genetically distinct from MEN1 and is caused by germline gain-of-function mutations in the RET proto-oncogene. As noted earlier, the RET proto-oncogene encodes a receptor tyrosine kinase that binds glial-derived neurotrophic factor and other related ligands and transmits growth and differentiation signals. Loss-of-function mutations in RET result in intestinal aganglionosis and Hirschsprung disease. In contrast, in MEN2A, germline mutations constitutively activate the RET receptor. MEN2B has significant clinical overlap with MEN2A. Patients develop medullary thyroid carcinomas, which pineal gland. The rarity of clinically significant lesions justifies brevity in the consideration of the pineal gland. It is a minute, pinecone-shaped organ, weighing to mg and lying between the superior colliculi at the base of the brain. It is composed of a loose neuroglial stroma enclosing nests of epithelial-appearing pinocytes, cells with photosensory and neuroendocrine functions. Silver impregnation stains reveal that these cells have long, slender processes reminiscent of primitive neuronal precursors, intermixed with the processes of astrocytic cells. The principal secretory product of the pineal gland is melatonin, which is involved in the control of circadian rhythms, including the sleep-wake cycle, are usually multifocal and more aggressive than in MEN2A and pheochromocytomas. However, unlike in MEN2A, primary hyperparathyroidism is not present. In addition, MEN2 billions is accompanied by neuromas or ganglion neuromas involving the skin, oral mucosa, eyes, respiratory tract, and gastrointestinal tract, and a marfanoid habitus, with long axial skeletal features and hyperextensible joints. Previously, families with isolated medullary thyroid carcinomas and germline RET mutations without additional features of MEN2 billions were classified as a separate entity, but have recently been grouped under the umbrella of MEN2 billions. A germline missense mutation leading to a single amino acid change in RET, distinct from the mutations that are seen in MEN2A, seems to be responsible for virtually all cases of MEN2 billions. This point substitution affects a critical region of the tyrosine kinase domain of the protein and leads to constitutive activation of RET in the absence of ligand. In contrast to MEN-1, in which the long-term benefit of early diagnosis by genetic screening is not well established. Diagnosis via screening of at-risk family members in MEN2. A kindred is important because medullary thyroid carcinoma is a life-threatening disease that can be prevented by early thyroidectomy. According to updated recommendations issued in, all patients with medullary thyroid carcinoma are advised to undergo germline RET mutation testing, since even apparently sporadic cases might harbor a germline mutation, which has implications for genetic counseling and testing for unaffected family members. Routine genetic testing identifies RET mutation carriers earlier and more reliably in MEN-2 kindreds. All individuals carrying germline RET mutations are advised to undergo prophylactic thyroidectomy to prevent the inevitable development of medullary carcinomas. MEN has emerged as a new entity in the past decade. These patients have clinical features that phenocopy MEN patients, but in contrast to that syndrome, harbor germline CDK and B mutations, leading to reduced levels of the cell cycle checkpoint protein, P, hence the popular use of melatonin for the treatment of jet lag. All tumors involving the pineal gland are rare. Most arise from sequestered embryonic germ cells. They most commonly take the form of so-called germinomas, resembling testicular seminoma or ovarian dysgerminoma. Other lines of germ cell differentiation include embryonal carcinomas, choriocarcinomas, mixtures of germinoma, embryonal carcinoma, and choriocarcinoma, and, uncommonly, typical teratomas. Whether to characterize these germ cell neoplasms as pinealomas is debated, but most pinealophiles favor restricting the term pinealoma to neoplasms arising from the pineocytes. Pinealoma. These neoplasms are divided into two categories, pinoblastomas and pinocytomas, based on their level of differentiation, which in turn correlates with their aggressiveness. These tumors are rare and are described in specialized texts. Suggested readings: Pituitary, Asa S., Mead O. What's New in Pituitary Pathology? Histopathology 72, 133-141, 2018. A review on the updated WHO classification of pituitary tumors and other non-neoplastic entities. DeCock L. Sabagian N. Plordef et al. Pituitary blastoma, a pathogenomic feature of germline Deseri mutations, Acta Neuropathol 128, 111-122, 2014. Dicer1 is a critical node in microRNA processing, and this study identifies one of the neoplastic manifestations of germline Deseri mutations that arise in the pituitary. Lopes MBS, the World Health Organization classification of tumors of the pituitary gland. A summary: Acta Neuropathol 134-521-535, 2017. The WHO classification of pituitary tumors was updated in 2017, and while a full description of the changes is beyond the scope of this book, this review provides the reader with a quick overview. Schertiner, Reiter M.H., Straticus C.A., Luger A., Genetics of Diabetes Insipidus, Endocrinal Metab Clin North AM 46305-334, 2017. An updated review on the molecular mechanisms underlying diabetes insipidus. Thyroid. Aquaviva G. Visani M. Rapacia et al. Molecular Pathology of Thyroid Tumors of Follicular Cells. A review of genetic alterations and their clinic pathologic relevance. Histopathology 726-31, 2018. A review on genetics of thyroid neoplasms on how the landscape of thyroid neoplasms has changed over time, with excellent summary figures on the multi-step pathogenesis of invasive thyroid cancers from precursor lesions. Cabanillas M., McFadden D.G., Durante C., Thyroid Cancer, Lancet 388, 2783-2795, 2016. A clinically to 3 to DeLeo S., Lee Tsai, Braverman Lay, Hyperthyroidism, Lancet 388 906-918, 2016. A clinically oriented review on the causes and main therapeutic avenues in hyperthyroidism. Ganley I., Makarov Vifi, De Rage S. et al. Integrated genomic analysis of Hürthle cell cancer reveals oncogenic drivers, recurrent mitochondrial mutations, and unique chromosomal landscape. Cancer Cell 34, 256-270, 2018. The molecular profiles of Hürthle cell carcinomas, including unique genetic features that underlie their distinctive morphology. Graves R.J., a newly observed affection of the thyroid gland in females, London Med Surg or 7516-517, 1830. A classic publication describing the index case of the disease named after the author. Gull WW, on a cretinoid state supervening in adult life in women, Trans Chin Sok Lun 7, 180-185, 1873.
Hashimoto hat zur Kenntnis der Lymphomatosenveränderung der Schilddrüse. Arch Kain 97-1912, Dr. Hashimoto, a Japanese physician trained in pathology in Germany.
Which might explain why his paper describing the eponymously named condition in 4 patients was originally published in German. Landa L., Ibrahim Pasik T., Busai L. et al. Genomic and transcriptomic hallmarks of poorly differentiated and anaplastic thyroid cancers. Clin Invest 126, 1052-1066, 2016. Nikiforov Ye, Saithala R.R., Talini G. et al. Nomenclature revision for encapsulated follicular variant of papillary thyroid carcinoma, a paradigm shift to reduce overtreatment of indolent tumors. JAMA. Oncol 2, 1023-1029, 2016. A seminal paper that introduced the term non-invasive follicular thyroid neoplasm with papillary-like nuclear features, in light of the overdiagnosis and overtreatment of this subtype of essentially benign papillary cancers. Smith 11, Hegedus L., Graves' disease, N. Engel J. Med. 375, 1552-1565, 2016. A comprehensive review on the pathophysiology, clinical manifestations, and treatment strategies in Graves' disease. Your one-stop shop for this topic. Parathyroid. Machado N., Wilhelm S.M. Diagnosis and Evaluation of Primary Hyperparathyroidism, Serg Clin North AM 99649-666, 2019. A clinically oriented and up-to-date review on the causes, symptoms, laboratory findings, and treatment of hyperthyroidism. Manstadt M. Bilazikian J.P., Thacker R.V. et al., Hypoparathyroidism, Nat Rev Dis Primers 3, 17055, 2017. Similar to other reviews in this primer series, this is a well-illustrated overview that helps supplement the text we have covered in this chapter with additional details. Simons W.F., Genetics of Hyperparathyroidism, including parathyroid cancer, Endocrinal Metab Clin North AM, a comprehensive review on the underlying genetic abnormalities contributing to hyperthyroidism, including neoplasms. Pancreas, diabetes, Check MP, insulin action and resistance in obesity and type diabetes, Nat Med. JA comprehensive review on the pathophysiology of obesity and insulin resistance in type 2 diabetes with some wonderful summary figures on the interplay between the pancreas, liver, adipose tissue and muscle. DeFranzo Ra, Farinini E., Group L et al., Type 2 Diabetes Mellitus, Nat Rev Dis Primers 1-15019, 2015. Although wildly dated, this illustrated review is a great overview of type diabetes that supplements many of the aspects we have covered in this chapter. Drucker D.J., Habener J.F., Holst J.J., Discovery, Characterization, and Clinical Development of Glucagon-like Peptides, Orklin Brost 127 4217 to 4227 2017. JGLP receptor agonists have emerged as one of the most important therapeutic options in diabetes, and this review provides a historical timeline and mechanisms of action of GLP agonists in human diseases. This is worth reading to understand how complex and drawn out the process of successful drug development can be. Gloin Al, Drucker D.J., Precision Medicine in the Management of Type 2 Diabetes, Lancet Diabetes Endocrinol 2018. $2,213 minus $8,587 $30,052-4. JAR review on how genetic underpinnings of type 2 diabetes can be used to tailor its management in patients. Goodarzi Mo, Genetics of obesity. What genetic association studies have taught us about the biology of obesity and its associations? Lancet Diabetes Endocrinol 6, 223-236, 2018. No other parameter is as paramount to the pathogenesis of type 2 diabetes as obesity and associated insulin resistance. This review discusses the genetic underpinnings of obesity and how this reflects on the obesity-diabetes axis. Katsuru A. Gudbjornsdottir S. Roshani A. et al. Type 1 Diabetes Mellitus, Nat Rev. Dis Primers 317 2017. A wonderful overview of type diabetes, including epidemiology, genetics, clinical symptoms, and treatment, complete with easy-to-absorb graphs and tables. Langenberg C. La. Genomic Insights into the Causes of Type 2 Diabetes, Lancet 391, 2463-2474, 2018. A recent review on the polygenic architecture of type 2 diabetes, including genetic features implicated in each of the underlying pathophysiologic mechanisms, such as beta cell dysfunction, insulin resistance, and adiposity. Lee Weiss, Wallum J., Olevsky J. M., An Integrated View of Immunometabolism, Cell. Many of the consequences of obesity, including insulin resistance and type diabetes, have their basis in a state of chronic inflammatory dysfunction. This review ties together how inflammation eventually leads to metabolic deregulation. Pugliese A. Autoreactive T cells in type diabetes, J. Klinninvest. Samuel V. T. Schulman G.T. The pathogenesis of insulin resistance, integrate iNG signaling pathways and substrate flux, J. Klinninvest 126, 12-22, 2016. There are many comprehensive reviews on insulin resistance in type 2 diabetes, given its paramount importance to the pathogenesis of hyperglycemia. A couple are included in the bibliography. Take your pick. Pancreas neuroendocrine tumors, Inzani F. Petrone G. Rindi G. The New World Health Organization classification for pancreatic neuroendocrine neoplasia, endocrinol metab clin north AM 47 463 470 2018. The WHO has recently updated the classification of neuroendocrine neoplasms of the GI tract, including PANETs, and this review summarizes the key distinctions from previous Chinal. P.A. Harubin R.H., Wood L.D., Genetics of Pancreatic Neuroendocrine Tumors, Implications for the Clinic, Expert Rev. Gastroenterol Hepatol 9, 1407-1419, 2015. JA Relatively Recent Review on Newly Identified Genomic Aberrations in Pancreatic Neuroendocrine Tumors and How These Can Form the Basis for Personalized Therapy. Adrenal Cortex, Addison T. On the Constitutional and Local Effects of Disease of the Suprarenal Capsules, London, Samuel Hiley. The Original Description of Addison Disease. Sharmandari E., Nicolaides N.C., Krausas G.P., Adrenal Insufficiency, Lancet, Hernandez Ramirez L.C., Stratakis C.A., Genetics of Cushing Syndrome, Endocrinol Metab Clin North AMI. An exhaustive on the genetics of Cushing syndrome, including somatic mutations underlying pituitary and adrenal PLA, Husby E.S., Anderson Miss, Camp A.O., Autoimmune Polyendocrine Syndromes, N. Engel J. Med 3,781,132, 3,000,007. A View on the Genetics, Pathophysiology, and Clinical Manifestations of Autoimmune Polyendocrine Syndromes. Loriot D.L., Diagnosis and Differential Diagnosis of Cushing Syndrome. N. Engel J. Med 376, 1,451-1,459, 2017. A fairly recent dymically oriented review on the etiopathogenesis, laboratory diagnosis, and treatment of Cushing syndrome. This review is a great place to get started. Mackay I. Aspinall S. Advances in our understanding of the prognosis of adrenal incidentalloma. Expert Re-Endocrinol Metab 11-529-541 2016. A review that addresses the prevalence, etiology, diagnostic workup, and treatment of incidentally discovered adrenal nodules. Montecone S., Buffalo F., Teddy M. et al., The Expanding Genetic Horizon of Primary Hyperaldosteronism, Ur J. Endocrinol, 178, 101-111, 2018. JA Review on the Genetic Factors Underlying Primary Hyperaldosteronism, including Sporadic and Familial Disease. Rushworth R.L., Torpy D.J., Falham R.H., Adrenal Crisis, N. Engel J. Med 381, 852-861, 2019. JA Review on the Causes, Pathophysiology, and Treatment of Acute Adrenal Crises.
Rena Medulla. Friedrichsen C. Nebennierenapoplexie bei kleinen Kindern. Jahrbuch für Kinderheilkunde 709-125. 1918.
One of the two original descriptions of the eponymously named Waterhouse-Friderichsen syndrome, Carl Frederiksson, was a Danish pediatrician. Lam A.K. Update on adrenal tumors in World Health Organization of endocrine tumors, Endocrine Pathol. This commentary summarizes the major changes to the classification and genetics of adrenal neoplasms, including data from the recently completed integrated molecular analysis of pheochromocytoma and paraganglioma. Waterhouse R. A case of suprarenal apoplexy, Lancet 1, 577-578, 1911. The second of two papers, this one authored by Rupert Waterhouse, an English physician, that led to recognition of the eponymous syndrome. Multiple endocrine neoplasia, LJWY, Hua X, Reedy Lagunas D. et al., menin loss as a tissue-specific driver of tumorigenesis, mole cell endocrinal. A recent review on the cellular functions of menin and the consequences of its abrogation leading to neuroendocrine tumorigenesis. Potential therapeutic approaches are also discussed. Pacheco M.C., Multiple endocrine neoplasia, a genetically diverse group of familial tumor syndromes, J. Pediatrigen 589-97 2016. JA review on the subtypes, genetics, and pathology of men syndromes. The skin, more than a mechanical barrier, disorders of pigmentation and melanocytes. Freckle lentigo melanocytic nevus, dysplastic nevus melanoma, benign epithelial tumors. Seborrheic keratosis 1142. Acanthosis nigricans, 1143, fibroepithelial polyp, 1143, epithelial or follicular inclusion, cyst 1143, adnexal tumors, 1143, epithelial or follicular inclusion, actinic keratosis 1145, squamous cell carcinoma 1146, basal cell carcinoma 1147. The skin, more than a mechanical barrier. More than a century and a half ago, the noted pathologist Rudolf Virchow described the skin as a mere protective covering for more delicate and functionally sophisticated internal viscera. Subsequently, the skin was viewed as a necessary but rather uninteresting barrier to fluid loss and mechanical injury. Over the last several decades, however, the skin has come to be appreciated as a surprisingly complicated organ, the largest in the body, in which precisely regulated cellular and molecular interactions govern many essential processes. Although the human integument may appear drab compared with the skin and pelage of other members of the animal kingdom, it is extraordinarily vibrant with regard to the diversity of functions that it carries out. Chief among these is its role as one of the first lines of defense against potentially harmful infectious and physical agents. However, tumors of the dermis 1149, benign fibrous histiocytoma 1149, dermatofibrosarcoma protuberans 1150, tumors of cellular migrants to the skin 1151, mycosis fungoids 151, mycosis fungoids 1150, tumors of cellular inflammatory dermatosis 1153, urticaria 1153, acute eczematous dermatitis 1154, erythema multiforme 1156, chronic inflammatory dermatosis 1156, 1154. Alexander J. Lazar. Chapter contents: blistering diseases, inflammatory blistering disorders, pemphigus bullous, pemphigoid dermatitis, herpetiformis, non-inflammatory blistering disorders, epidermolysis bullosa and porphyria, disorders of epidermal appendages, acne vulgaris, rosacea, paniculitis, erythema nodosum, and erythema induratum, other types of paniculitis infection.
Verrucae 1167, molluscum contagiosum, 1168. Impetigo, molluscum contagiosum, contagiosum.